Okay, now coming towards carcinoma of pancreas, we are having a scenario that there is a 60-year-old male present with jaundice, dark color urine, and clay colored stool. Investigation, differential diagnosis, and treatment. We have to write that. Another scenario we are having that there is a male with periampullary carcinoma. Prep for surgery. Name of minimally invasive procedure likely to be used to relieve symptoms. What are the complications? 3 post-op complications if undergoes major surgery. So the carcinoma of pancreas, it has worst prognosis of all the malignancies. In 80% it is ductal adenocarcinoma, 70% occurs in head, 20% in body, and 10% in head. It involves the duodenum. Its invasion involves the duodenum, local lymph nodes, portal vein, and mesenteric artery, metastasis to the liver, peritoneum, and lungs. Ampullary carcinoma and periampullary carcinoma. We are having two types. In ampullary carcinoma, ampulla is junction of the biliary and pancreatic duct within duodenum, and it is having good prognosis. While periampullary carcinoma, tumor arises within 2 cm of the ampulla, include tumor of distal bile duct, duodenal mucosa, and pancreatic head, and it is having good prognosis. Now, the risk factors for carcinoma of pancreas are that its age at the age of greater than 65 years, it is more common in male gender and black ethnicity, smoking, diabetes, and adenomas. Familial adenomatous polyposis, positive family history, chronic pancreatitis, and familial breast ovarian syndrome. Now, coming towards the clinical features, jaundice obstructive due to obstruction of the distal bile duct organ. Pruritus may happen, dark urine and pale stool is present, back pain indicates retroperitoneal infiltration, weight loss, palpable gallbladder, weight loss, anorexia, and advanced tumor, blocked duodenum, and gastric outlet obstruction. Tumors of the neck, body, and tail of pancreas usually diagnosed at late stage because do not cause jaundice. Kurva's law. This is a law about the palpable gallbladder, and it says that the gallbladder is palpable if there is malignant obstruction, and it will be not palpable if the cause is stones or any other cause. Okay, what investigations we will do for the carcinoma of pancreas? First of all, we will do the bilirubin level, that will be raised, alkaline phosphatase and gamma glutamyl transpeptidase. Then we will do the ultrasonography. This is the initial investigation, non-invasive. The dilatation of intrahepatic and extrahepatic biliary tree, cholelithiasis, choledocholithiasis, and mass lesion can be identified. Endoscopic ultrasonography and CT scan is the investigation of choice, which demonstrate dilated biliary channel, level of obstruction, size and site of tumor, the relation of tumor with vessels, portal vein, celiac axis, then the MRI and MR angiography, then laparoscopy, peritoneal and hepatic metastasis, and carcinoma 19-9 to monitor the treatment response. Now coming towards the treatment, the 80% of unresectable because disease is too advanced and 80% palliative treatment is provided. The 15 to 20% is curative treatment. Now in curative treatment, we are having the surgical resection and the first full investigation. Contraindication for surgeries are livers and lungs metastasis, peritoneal metastasis, encasement of the superior mesenteric, hepatic or celiac artery, complete encasement of portal vein, although not absolute contraindications. Okay, findings which are not contraindicated, that is tumor size, invasion of the duodenum, stomach or colon, lymph node involvement, operative field, minimal invasion of the portal or superior mesenteric vein, and part of vein can be resected. Now the pre-op prep for the patient. Majority patients are jaundice, so increased risk of hepatorenal shutdown, cholangitis, hypoglycemia, and clotting factors abnormality. So intravenous fluid is given, that is renal perfusion, adequate urine output, vitamin K injection is given, 10% dextrose water is given, liver loses storage function of the glucose. Prophylactic antibiotics are given, cholangitis, pre-op biliary drainage of if bilirubin is greater than 10 mg per dl. Now we are having the surgical options. These are the tumor of head and ampulla. Whipple's procedure is the surgical option, which is following structures are removed. Tumor along with the head and neck of pancreas, entire duodenum, proximal 10 to 15 cm duodenum, lower end of the stomach, common bile duct, gallbladder, lymph nodes, and around vicinity of pancreas. Okay, pancreato-duodenostomy. After removing these structures, duodenum is anastomosed with pancreas, hepatico-duodenostomy, gastro-duodenostomy, and pancreatico-duodenostomy. Tumor of body and tail, distal pancreaticotomy with splenectomy, chemotherapy, radiotherapy, limited for pancreatic carcinoma. A palliative treatment is symptomatic treatment. Aim is relieve jaundice, gastric outlet obstruction, and pain. relief jaundice. For relieving the jaundice stunting in common bile duct through ERCP or PTC, then surgical bypass. There is common bile duct is anastomosed with duodenum, choledochoduodenostomy to drain bile. Okay, then relief of gastric obstruction, relief by anastomosing stomach with duodenum, gastroduodenostomy or bypassing stent into the duodenum. The third option is relieving the pain. So analgesics are used and celiac access is blocked, improving quality of life, encourage normal activities, pancreatic enzyme replacement, and the treatment of diabetes. Chemotherapy is provided, but it has limited role. Now, what are the complications of carcinoma of pancreas? These are bleeding, pneumonia, pancreatic fistula, bile leak, chylous ascites, MI, wound infection, delayed gastric emptyings. The prognosis is dependent upon size, site, type, involvement of lymph nodes, and neurovascular invasions. 5-year survival of the ampullary cancer, cholangiocarcinoma, and pancreatic ductal adenocarcinoma. Those with unresectable pancreatic adenocarcinoma has medium survival of 9 months. So what we have studied in the carcinoma of pancreas, first of all we discuss the scenario, that what will be the clinical features and what will be the diagnostic points to identify that it is a carcinoma of pancreas. Then we discuss the prognosis rate, then the invasion of the carcinoma of pancreas, then its type, which are ampullary and periampullary carcinoma, then the risk factors, who are at more risk. Then we discuss the clinical features that a patient will come with. Then we discuss the Courvoisier's law, that the gallbladder will be palpable or not. So if the case is malignancy, then the gallbladder will be palpable. If the gallbladder is not palpable, then it means that the case is not malignancy. It may be either stones are present or some other causes. So the investigations that we will do is raised bilirubin, ultrasonography, endoscopic ultrasonography, CT scan, MRI and MR angiography, laparoscopy and carcinoma 19. Now we are having the treatment options. These are palliative treatment and curative treatment. The palliative treatment is 80%, while the curative treatment is 20%. And curative treatment, we will do the surgical resection, first full investigations, then the contraindication for surgery, and then findings which are not contraindicated. Then what is the pre-op preparation of the patient? Then what are the surgical options? Then we discuss the Whipple's procedures, the different surgical options, that are pancreaticoduodenostomy, hepaticoduodenostomy, gastroduodenostomy, pancreaticoduodenostomy, and tumor of body and tail. Then the palliative treatment, we are having relief of the jaundice, relief of gastric obstruction, relief of pain, improving quality of life, and chemotherapy. Then what are the complications and what is the prognosis? Now coming towards the acute peritonitis. Okay, so we are having a scenario that there is a 43-year-old patient, man, 2-day history of pain in epigastric region. On examination, he is dehydrated. Heart rate is 110 per minute. PP is 90/70. Abdomen is tender, guarding and rigidity, pyrexia, decreased bowel sounds are present. So what are the causes of pneumoperitoneum? What is the management option? What are the treatment options? And what are the 4 complications? Inflammation of the peritoneum. We are having primary peritoneum, that is peritonitis, and secondary peritoneum, that is the secondary peritoneum is cause 40% mortality, and it is a serious case. So in primary peritoneum occurs when microbes from distant site invade the normal site normal sterile confines of peritoneal cavity via homogeneous dissemination. 15% of the acute abdomen emergency. Now the causes of primary peritoneum are nephrotic syndrome, liver cirrhosis, chronic renal failure. The clinical features are abdominal pain, tenderness, rigidity, and ascites. The investigations that we will do are laparoscopy, laparotomy, leukocytosis, lack of the pneumoperitoneum, diagnostic paracentesis, and the treatment options are antibiotic therapy. Okay, the secondary peritoneum we occur due to the contamination of peritoneal cavity due to perforation or severe inflammation and infection of intra-abdominal organs. Then the causes are appendicitis, diverticulitis, GI tract, and perforation. The clinical features are generalized abdominal pain, tenderness, rigidity, signs of toxicity, and hypovolemic shock. The investigation that we will do are like leukocytosis and under diaphragm, CT scan of the abdomen. The treatment options are intravenous fluids, antibiotics, Foley catheter, correction of the electrolytes, blood test, CBC, electrolyte, urea, creatine, LFTs. Definite treatment is wash abdominal cavity, repair perforated duodenal ulcers, necrotic tissues, debridement, gangrenous segment resected, perforated small bowel repair, and colonic perforation, exteriorized. Now, the clinical features depend whether localized or generalized. Generalized abdominal pain, tenderness, rigidity, signs of systemic toxicity, and hypovolemic shock is present. These are the localized clinical features. The generalized are severe abdominal pain, persistent vomiting, increased pulse rate, high grade fever with chills and triggers, cough, tenderness, rebound tenderness, guarding, and rigidity. Bowel sounds are absent. The investigation options that we will do are CBC, CRP that will be raised, X-ray chest and abdomen is done, abdominal ultrasound and CT scan is done, and peritoneal aspiration is done for pus that is bacterial peritonitis and blood that is intraperitoneal bleeding and amylase estimation. The treatment options are general care of the patient, then the neutralization of the local source, then the conservative treatment. So, the general care of the patient, we will do the aspiration, intravenous fluids are given, drugs are given, and charts for temperature, pulse, and respiratory rate is prepared. In the neutralization of local source, surgery is done, which is indicated in perforated appendicitis, perforated diverticulitis, perforated peptic ulcer, perforated gangrenous cholecystitis. The conservative treatment is provided. Now, complications of peritonitis, these are specific and general. In specific, additional acute intestinal obstruction, paralytic ileus, residual abscess, subphrenic paracolic appendicular pelvic portal pyema and liver abscess. In general, bacterial endotoxin shock, bronchopneumonia, respiratory failure, electrolyte imbalance, renal failure, bone marrow suppression, and multi-system breakdown. These are the general complications of the peritonitis. So, what we discuss in the acute peritonitis, first we discuss the scenario that there is a patient and having 2 days history of pain in epigastric regions, and he is dehydrated and heart rate is 110, BP is 90, and abdomen is standard and rigid, and he is also having a pyrexia and decreased bowel sounds. So this is the inflammation of the peritoneum. Then we are having two types. These are primary peritoneum and secondary peritoneum. Then we discuss the causes of each and clinical features, investigations, and the treatment options. Then the clinical features are localized and generalized. Then we discuss investigation options. Then we discuss the treatment options, which are general care of the patient and the neutralization of the local source and the conservative treatment. Then we discuss the complications of peritonitis, which are both specific and general. In our next part, we will start from the lower GIT, and we will try to cover the lower GIT in two sections, two videos. The upper GIT is already discussed in the first two sections, and this is the last section of the upper GIT. In our next video, we will start the lower GIT. Thanks for watching.